So I should starting, sir. 66 years old male, a resident of Jodhpur, shopkeeper belonging to the middle socioeconomic status, presented with complaints of bleeding for rectum, loss of weight and loss of appetite for the past 30 days, and constipation for the past 15 days. Uh, he was apparently well 1 month back when he developed complaints of painless passage of dark red blood mixed with stools since the past 30 days. Insidious onset, initially once every 2 days, now accompanied by every stool passage, roughly 50 ml in quantity, not associated with pain during defecation or bleeding post passage of stools, or no history of posterior syncope or dizziness, no history of awareness of mass protruding per rectum or of similar complaints of bleeding in the past, no history of mucus discharge or early morning passage of bloody stools mixed with mucus, no history of bleeding on trivial trauma, ecchymosis, melena, or gum bleeds. He has history of, and there is no history of passage of blood clots. He has history of loss of weight, not documented, evidenced by loosening of clothes over past 30 days and associated with loss of appetite. Initially, he was able to consume 5 to 6 rotis per day, now only 2 rotis per day. He has associated complaints of weakness and has consequently been unable to work for the past 7 days, but is able to go to work for the past 7 days, but is able to carry out his activities of self-care. Insidious onset complaint of constipation for the past 15 days with an accompanied decrease in frequency of stools from once every day to once in 3 days and almost twice per week, accompanied by straining during passage of stools and feeling of incomplete evacuation post-passage. No history of change in the caliber of stools or of manual evacuation of stools or use of stool softeners. No history of aggravation of bleeding post-constipation or abdominal distension and pain or of obstipation and vomiting. No history of any abdominal or perianal pain, pain relating to thighs or back with perianal fullness. No history of perianal discharge, awareness of a lump in that region. No history of incontinence to gas or stools or soiling of undergarments. No history of insertion of foreign body per rectum or of any psychiatric illness in the past. No history of blood transfusions in the past or urinary complaints. The patient is not sexually active. No complaint of jaundice, fever, cough, alteration of consciousness, bony pains, headache, or breathlessness. Should I continue, sir?
Okay, so that was basically the history. Before going to the systemic history, let's just go back to your history. And
Yes,
can you just elaborate upon, I mean, you've actually taken a very elaborate history and it's very good pertaining to the actual symptoms. But can you elaborate upon what are the positive findings in your history? And what is your understanding with those positive findings on the history?
So
At this point of time, we are not discussing the further history and the examination. At this point of time, what are the positive features and what is your understanding based on those positive features on the history?
So the positive findings are history of painless passage of dark red blood mixed with stools and associated with incomplete evacuation. Associated with the history of loss of weight and loss of appetite, and constipation since the past 15 days associated with incomplete evacuation. And my understanding would be, considering the shorter duration of history, I would consider this like to keep probably a malignant cause as one of differentials, or it may be a simple rectal polyp which is causing the bleeding. But I would like to comment on this further after confirming with my examination.
I think, I'm sorry, there was some voice disturbance. May I request everyone to keep himself?
Wrongly written as MRI CT protocol. CT is not required. Yes, contrast. Yes, PAT is high. They shouldn't give contrast.
May I request Dr. Vivek to please mute himself? There was some voice disturbance. I'm sorry, I could not hear the last part of what you mentioned, but I believe you were mentioning that based on the positive history that you have taken, you believe it's a polyp, is it?
Sir, it could be a bleeding polyp, or it could be also a malignant etiology of the colon. Or I could also, at this point, like to keep other benign etiologies unless I examine the patient, like hemorrhoids or lower down my consideration order.
Okay, you mentioned that the patient has loss of weight and loss of appetite in the last 15 days only.
30
You
days, yes, sir.
last 30 days. You mentioned that he has had constipation only in the last 15 days, and the blood with stool started only 1 month back. So three symptoms started together. One was blood with stools, second was loss of weight and loss of appetite, and 15 days later, it was then accompanied with constipation also.
Yes, sir.
Now, first of all, if the patient has loss of weight over a period of 1 month, I think you should have quantified it and probably elaborated upon it, because it is not usually easy to make a very definite comment about loss of weight over a duration of just about 1 month. So what was the kind of loss of weight?
Sir, it was not documented, and it was evidenced by the patient in the form of loosening of his clothes.
Only for the last 1 month.
Yes, sir, in the last 1 month.
Okay. And loss of appetite?
Sir, loss of appetite is he initially consumed around 6 rotis per day. Now it has decreased down to 2 rotis per day. And also associated with the loss of weight and loss of appetite is generalized weakness that the patient is experiencing, due to which he is unable to go to work and for the past 7 days.
Okay. So now this again has been over the last 30 days only. Now
Yes, sir.
it becomes important to understand from a detailed history whether it was all because of the loss of blood which he was having for the last 1 month. You were saying that every day he loses about 50 ml of blood. Is that true?
Yes, sir. So, till the past 15 days, when he started having new onset constipation, when he used to go once in 2 or 3 days, there was no bleeding without passage of stools in the past 15 days.
Yeah, and
Within once in every 2 to 3 days, he had bleeding episode of 50 ml per episode.
yeah, so which would mean that he has already lost about 700 to 800 ml of blood,
Yes,
which
sir.
would mean that he should have gross anemia, which would
Yes, sir.
mean that he should have other symptoms related with gross anemia,
Yes, sir.
possibly or maybe not sometimes. So what is your understanding based on the history that you have given? First of all, whether it goes in favor of benign or malignant. Secondly, what should be the location of the pathology? Thirdly, is this pathology, localized or systemic? What information do you extract out of this?
Sir, more likely, I would like to keep malignant etiology above due to the shorter duration of history, significant loss of appetite, and loss of weight, and as experienced by the patient. And the locations are, I would like to keep preferably colorectum, rectum over colon, and the etiology in the malignancy, I would like to keep carcinoma of the rectum, a bleeding polyp of the rectum as one of my differentials. And the second point, sir, which you mentioned, that attributable to the loss of blood, anemia could be there, which could be causing the weakness. Yes, I agree, but new onset constipation does not accompany for the same. But I would also consider at this point of time very lower down benign etiology like hemorrhoids, but very lower down. And the location in the rectum.
तो एक जयपुर नामक जयपुर में एक
May I request?
आपको होता ना
May I?
जयपुर सर्जिकल क्लब है बीके कपूर और कौन सा आई डोंट नो ये वर्क इन सम उधर से वो करता है.
And in the rectum, the location probably would be a mid to lower rectum. of the disease.
Okay. So what lesions which are bleeding so profusely also lead to constipation?
Sir, it can
And
be a
and rectal, you are saying the rectal location. So you are expecting a rectal lesion which is bleeding profusely and also has given rise to constipation in the last 2 weeks.
yes, sir.
So
It
with
could
that
be,
positive finding, what is your understanding?
sir, it could have been a small polyp which has increased in size, or a growth which has gradually increased and compromised the lumen. Now it could ranging from a polyp to a growth to even angiodysplasia. I would have considered if only bleeding was there, but now it is causing probably the luminal compromise and causing constipation also. So it is now causing compression or compromise of the lumen. So a growing fast enlarging polyp, bleeding polyp, or a
What polyp can produce constipation? Polyps don't usually produce constipation. They in fact produce mucus diarrhea and
Diarrhea.
blood loss, especially in villus adenoma. Why have you considered a polyp? If you're considering it's polyposis syndromes with malignancy, that's a different thing. But if you're thinking it's only a solitary polyp, like a juvenile polyp or a Puig-Hers polyp or whatever, this will not be the case. And weight loss, significant loosening of clothes should point you in another direction, whether the lesion has become metastatic, whether it's a systemic disease, that suggests that, or it could suggest that there is intestinal obstruction and the patient's intake of food has reduced. But loss of appetite and loss of weight should point you in the direction of metastatic disease.
Sir, since the history started with bleeding, I kept maybe a polyp which has undergone a malignant transformation and is causing a growth like lumen-like compromise. So second point, there is metastasis can be there, but there is no history. There is no history suggestive of overt mets. But yes, I agree that the loss of weight, significant loss of weight and loss of appetite, could be a pointer towards that. And the third point, that intestinal obstructions are, he does not have any overt complaints of intestinal obstruction, but yes, constipation and altered bowel habits, they are there. It could be early luminal compromise, but not overt obstructions.
Okay, but constipation, passing stools in 2 to 3 days, which is not his usual pattern, signifies significant luminal compromise.
Yes.
And you will have to look for certain things in the clinical examination to support your support this historical knowledge that you have.
Yes, sir. Yes, sir.
Okay, let's go to the systemic history.
Sir, general examination, patient is conscious, oriented, and comfortable. He's averagely built and nourished. The pulse rate is 90 per minute, a BP of 130 by 80 with a respiratory rate of 16 per minute. His afebrile to touch, saturation on room air is around 98%. His performance status is ECOG performance status of 1, breath holding time of 30 seconds, BMI of 17.3 kg per square meter. Pallor is present. Icterus pedal edema, generalized lymphadenopathy, and left supraclavicular lymphadenopathy is absent. On inspection, the abdomen is flat and all quadrants moving equally with the respiration. Umbilicus is centrally placed. There is no visible hypertrophy is normal.
I'm sorry to interrupt. Can I request Dr. Saurav to please mute himself? Dr. Saurav, please mute yourself. Dr. Saurav, can you please mute yourself? Thank you.
On palpation, the inspected findings are corroborating. There is no local rise of temperature. Abdomen is soft and non-distended. Liver and spleen are not palpable. There is no other palpable mass, and hernia is free. On percussion, the liver span is 12 centimeters in the right mid-clavicular line. There is no shifting dullness. And on auscultation, normal bowel sounds are heard and no accessory findings. On per-rectal examination, the perianal skin is within normal limits. No tag, sinus, or mass palpable. There's a firm ulcerative mobile growth.
And this is from
There is a firm ulcerative mobile growth palpable about 4 centimeters from the anal verge, 5 o'clock to 9 o'clock position, causing mild luminal narrowing. Overlying mucosa appears to be mobile. The upper extent is not palpable. No other mass or lump was palpable in the lateral or posterior walls. It is extending at least till where I could insert my fingers about 8 centimeters, 7 to 8 centimeters from the anal verge. The anal tone is within normal limits, and the patient is able to squeeze. The gloved finger shows traces of blood mixed with stools. Other systemic examination is within normal limits. The bone and spine, the respiratory, and the CNS, the inguinal lymph nodes are not palpable.
Okay, so is that all? What's your impression now?
Yes, sir. That is a 66-year-old male without any addiction of focus. The respiratory complaint of painless bleeding for rectum mixed with loss of weight and loss of appetite since past 30 days, and new onset constipation and incomplete evacuation since past 15 days. On examination, he has pallor with ECOG of 1 and a firm mobile ulcerative growth with lower extent 4 centimeters from anal causing partial luminal compromise. I would like to keep malignancy of the lower rectum with anemia as my differential diagnosis.
Okay, and how do you, let's try to explain everything that you've had as a positive finding on history and examination, and give us your impression based on that. So how do you explain everything that was positive on history and that's positive on examination? Are you able to get my question? No?
Yes.
Okay.
Sir, bleeding per rectum is the most common presentation of malignancy of the rectum, and it could have been ulcerative growth, which is ulcerating and bleeding from the tumor surface.
You mentioned, I'm sorry, you mentioned that this growth you could feel on the rectal examination, but you could not get above the growth.
Above. Yes,
Okay,
sir.
so
Yes,
this is a long growth and you could feel it at 4 centimeters, but the upper extent was beyond your finger.
At least it is a minimum 4 centimeters, because I could reach to 7 centimeters above the anal verge.
Yeah, so the
And
upper extent you were not aware, no?
No aware, not aware.
So you were not able to get above the growth, but you could feel the growth at 4 centimeters from the anal verge.
Yes, sir.
And the lumen was not compromised, or sorry, the lumen was
partially compromised.
Okay.
It was from 5 o'clock to 9 o'clock. It was not circumferential, 5 o'clock to 9 o'clock position. And it was ulcerative in nature, irregular surface, and the part of the overlying mucosa appeared to be free, and the anal tone appeared to be normal.
Okay. So yes, please.
Yeah. You said you couldn't get above the swelling. So in the absence of being able to get above the swelling, you cannot make any commentary on the luminal compromise. The entire extent of the growth has to be felt, and only then you can say that it's partially occupying the lumen, and it's not completely circumferentially constricting, because constipation with partial obstruction of the lumen doesn't explain. Weight loss doesn't explain. Liver span is 12 centimeters, but it still could be few metastases, so that's why the liver is not showing. If the liver is palpable, what is the liver border like? Are you able to feel any other lesions? Are you able to feel that the liver in the mid-clavicular line also you have measured, but you have to measure also in the mid-axillary line, because it might be the right lobe that is expanded in its extent and not the left lobe.
Sir, yes, sir, I agree, sir. The liver was not overtly palpable, although I would like to further investigate and find out that point. And in the examined territory, in the examined area, at least the lower until the mid rectum, where I could reach my finger, it was not completely occluding the lumen. But yes, the full extent I could not examine with my finger, and it appeared to be the overlying mucosa appeared to be free and mobile.
Okay. Okay. What is he frail? Does he have frailty?
He's not very frail, but yes, his performance status has dipped as told by the patient. I could probably attribute it to the anemia, the pallor, the anemia that he's having.
Okay.
Because he appears to be with a BMI of 17.4, he appears to be on the lower normal side, not on the lower side, but yes, he is not frail.
Okay.
So
Yeah, go on.
now we know that your patient has this growth, which you could feel at 4 centimeters. Now, what is your impression? What is your diagnosis, and what is your differential diagnosis?
My impression would still be that of a malignant etiology of the rectum, probably a carcinoma of the mid to lower rectum, and it is causing luminal compromise. That is why that explains his constipation. But I would like to evaluate the full extent and then comment further with pallor, with anemia. Sorry, with anemia.
So, what are you expecting? Are you expecting a locally advanced lesion?
Yes, sir. I'm expecting a locally advanced lesion owing to the symptoms and the weight loss.
So, are you what? No, try to be clear. Are you expecting a locally advanced lesion or a disseminated lesion?
Sir, I'm expecting a locally advanced lesion. No overt dissemination is there, but it may be a finding on further investigation. I'm expecting just a locally advanced lesion.
How do you define a locally advanced rectal cancer?
Sir, beyond either it has T3, T4, or nodes are positive, sir. Metastatic nodes are there in the mesorectum.
Is that known as locally advanced?
Sir, extending into the mesorectal fascia, I think beyond early rectal cancer, that is beyond T1, T2 with N0, and not having any distant overt metastasis.
No, I don't agree with you. Locally advanced rectal cancer. I mean, of course, there's no proper definition in the guidelines, but most of the literature would refer to a rectal cancer as locally advanced in 2 or 3 situations. One, when the circumferential resection margin is threatened, that is locally advanced. When it is very close to the levators in cases of lower rectal cancer, and the infiltration might be there, it is known as locally advanced. And thirdly, when it is going very close to the sphincters, that is known as, particularly the internal sphincter, that is known as locally advanced. But what you're trying to probably, or what you're getting confused with, is a late stage rectal cancer, which is not locally advanced. So early rectal cancer is T1, T2, N0. The rest is, I mean, what we don't define, but we don't categorically label as some kind of rectal cancer. So it can be T3, it can be N1, but it is all within the confines of the mesorectum. But when you say locally advanced, it means it is not within the confines of the anatomy of mesorectum that it becomes locally advanced. And when we say locally advanced, it obviously means that from the treatment and the management point of view, it has some implications, which we will discuss later. Okay.
Yes, sir.
All right. And here, very importantly, you must note that you have not mentioned any perianal pain in the history.
Yes, sir.
Okay. Now, when you say that there is no perianal pain in this patient, he has not given you, what makes you feel that this patient might have a locally advanced disease?
Sir, although there is no perianal pain suggestive of any nerve involvement or perianal heaviness, but the significant loss of weight that he has experienced and the deterioration in the performance status as evidenced from the history.
No,
And there's
you
a
are
mass which is 4 centimeters.
okay.
There's a mass which is minimum 4 centimeters extending in the length and causing luminal compromise.
Okay, let me try and correct you at this point of time. When we say locally advanced rectal cancer, it does not mean that it is always associated with a disseminated disease. In fact, it is very common in rectal cancer to have a locally advanced rectal cancer which has not disseminated to other places in the body. Okay. So it is certainly possible that a patient has a locally advanced rectal cancer with local symptoms like pain, okay, which may or may
Yes.
not be associated with other symptoms of loss of weight and loss of appetite, which could be because of the systemic disease. So don't get confused between the two. Locally advanced does not mean dissemination compulsorily.
Sir, he is not having any pain, but all these symptoms are likely to say that it might not be a very localized disease. It will be a locally advanced disease. And I'm not talking about metastatic, just locally advanced disease.
Yes. Okay. So let's go ahead. Sitaram sir, can you please comment?
Rajesh, Dr. Kapoor wanted me to give some general comments at the end of the presentation.
Okay. All right. All right.
5 minutes at the end. I will wait for that.
Right, sir. Thank you, sir. Thank you so
Thank
much. Thank you, sir. Okay, so what's your strategy of investigating this patient?
Sir, I would like to review any old records if available with the patient.
Okay.
And if first of all, in completion to my examination, I would also do a proctoscopy. And if I can visualize the mass, I would like to take a biopsy from the mass patient.
In this patient, in whom you could feel the tumor or the lesion with your finger on the digital examination, and based on the history and whatever your examination, you feel that there is a strong likelihood of this being malignant.
Yes, sir.
Why do you intend to do a proctoscopy? What help does proctoscopy offer you here?
Sir, with the the findings are just with my finger proctoscopy would help me better illuminate and see the mass lesion. Maybe take a guided biopsy also, and probably also could shed some light on the slightly upper part which I'm unable to examine, but mainly will help me with the biopsy from the mass lesion, help me make a diagnosis.
So would you choose proctoscopy in a patient who has a luminal compromise, wherein you were not able to reach the upper margin of the tumor? Would you like to do a proctoscopy and biopsy, or would you like to do a sigmoidoscopy?
Sir, a sigmoidoscopy actually is not available in the routine. Otherwise, a sigmoidoscopy would definitely be better than a proctoscopy. But in the clinical examination time, and the more readily available would be a proctoscope. That is why I mentioned a proctoscope. But if a sigmoidoscope is available, then yes.
So if you do proctoscopy and biopsy, can you rule out the need for sigmoidoscopy?
No, sir. I would definitely in the investigations go for a full length colonoscopy. But I wanted to start with the basic investigations. So hence I mentioned proctoscopy.
May I interrupt? Would you like to prepare this patient for a colonoscopy? Are you going to give him PEGLEC or
No,
any
sir.
of the
Preferably not, sir, because he's already having luminal compromise. He's having complaints of constipation. It might further aggravate the complaint, and he may land up in acute or severe obstruction.
that? So how are you going to do a colonoscopy? There will be impacted fecal matter all along the colon because it's a constricting lesion. Colonoscopy might not be so technically easy.
Yes, sir. Agreed, sir. It will not be easy, but if possible, as far as to the extent which they can see, I would like to do it later in the investigation panel, sir. A full length colonoscopy to rule out any synchronous lesion.
Okay, so you did a proctoscopy, and
Yes,
the proctoscopic biopsy shows a well-differentiated adenocarcinoma.
Yes, sir.
What next?
Sir, next, since I would like to also order the series of blood investigations, which I have not done in this case, and complete blood count because he was having bleeding PR and he has pallor,
Hmm.
along with kidney function test, liver function test, a prothrombin time,
Hmm.
PTINR, and also get an ultrasound abdomen and a chest X-ray in the same setting. In the basic.
Okay. So you got all those investigations done. The hemoglobin was 6.5. You transfused 2 units of blood over 2 days, and everything else was negative. The sonography was normal. The chest X-ray was normal. The liver function test and the kidney function test was normal, and there were no positive findings. And the biopsy shows well differentiated adenocarcinoma. How would you proceed?
Sir, now I've confirmed my diagnosis. I have a diagnosis. I would like to do a staging investigation in the form of a contrast and CT of the thorax and abdomen with MRI pelvis. MRI pelvis for the local staging and CT for the metastatic staging and CEA levels.
So I would have rather thought that you could have done the CEA levels along with the routine biochemistry that you were trying to do, because you take a single sample and you actually ideally should be, although it may not make a difference in such a big growth, but ideally before the rectal examination and on the basis of history, you could have taken the CEA sampling. That is one. Can you rule out the need for a colonoscopy despite the difficulty in trying to prepare the colon in this patient before going on to the entire staging investigations in terms of imaging?
Sir, if I'm not if I am having difficulty, yes, at the current point of time before going for the cross-sectional imaging, I can avoid the colonoscopy. But if I plan later, my plan is for surgery and or further management, then I would like to, before the surgery at least, I would like to have a full-length colonoscopy if feasible. But yes, before the imaging, I can probably wait, because I already have the tissue diagnosis. I have confirmed my diagnosis from the biopsy which was taken. But it is desirable to have a full-length colonoscopy before thinking of planning.
In your examination, you mentioned that the patient's abdomen was absolutely soft. There was no distension.
Yes,
You
sir.
did not mention any positive findings of palpable loops or fecalomas. So
Yes, sir.
we presume that the patient is moving his bowels, although constipated.
Yes,
And
sir.
you could put in your finger so that the lumen was only partially compromised. Do you think you should make a good attempt to clear the bowel and do a colonoscopy full length? Is it important? Because can it change your further strategy regarding the cross-sectional imaging?
Yes, sir. It is important, and at least
And what should be the
full.
sequence? What should be the sequence? Should you make an attempt to do the colonoscopy first, or should you jump onto the cross-sectional imaging before the colonoscopy findings?
Sir, if everything is soft, and yes, a gentle attempt can be made. I agree that not giving the full peg leg preparation, at least giving half the preparation or maybe less than that in the morning, observing the patient that he does not have a dilated bowel or does not go into obstruction, and then a trial for colonoscopy can be given even after gently cleansing the bowel, giving maybe gently parectal enemas. The colonoscopy is important before going for the imaging investigation, because as you mentioned that in case since I'm suspecting only an isolated rectal growth, then MRI pelvis would be the staging investigation of choice for my local staging. But if
Let's wait before we go to those aspects. Two important things that I would like to know from you. What is partial peg leg preparation and what is complete peg leg preparation that you mentioned? Because I'm not aware of that. One, can you elaborate on that? And
sir, I meant like
how do you give a peg leg preparation?
sir, one day before there is a sachet which comes, which you have to dissolve it in probably 1 liter or 2 liter of water, as the instructions are 2 packets.
Is it 1 liter or 2 liter?
Sir, it is 1 liter.
I'm sorry, it is 2 liters.
1 in the morning and yes, sir, 2 liters. And we have to give the patient over a period of 2 to 3 hours. He will consume that of the evening and cleans, and he will pass liquid stools. But if we are suspecting that it might be partially obstructed the system, then instead of giving the entire 2 liters, we can give 1 liter and not give the entire 2 liters to probably avoid him going into.
See, I think, it is very important for us to be very clear about such prescription orders, because it is from the doctors and the surgeons only that the nursing staff would learn or be careful about what we desire with this kind of preparation. Now, the standard recommendation for colonoscopy preparation includes mannitol. Okay. Mannitol on the previous evening, that starts later during the evening, say around 6 or 7 o'clock. That mannitol is not to be given intravenously, it is to be given orally. Okay. It is the same mannitol which is used by neurologists and neurosurgeons to decrease the cerebral edema, but it is to be given orally. It is a hygroscopic solution that gives rise to some stools. Then the next morning, and these are the standard preparations that you're supposed to write. Okay, so, and there are no two thoughts about it. It has to be very, very clear. The standard recommendation for PEGLEC is in the morning. It has to start at 5 o'clock or 6 o'clock in the morning. And you have to write that entire sachet has to be dissolved in 2 liters and the patient has to consume 1 glass every 10 minutes, which would mean about 200 to 250 ml every 10 minutes till the stools are clear. There is usually no scope for half the bowel preparation or half PEGLEC preparation, and one should rather avoid it. One should rather avoid it, not only from the colonoscopy point of view, but also before surgery if you're trying to achieve that, because liquid stools are more of a disaster than an uncleaned bowel with solid stools. So halfway has to be avoided. What you were trying to getting confused with was a partially obstructed patient who might get problems because of PEGLEC, where you're not sure whether the patient has the ability to consume the entire PEGLEC and he won't get distended. So we'll discuss that later. But for this kind of patient, you have to write PEGLEC to be dissolved in 2 liters of water, 1 glass every 10 minutes in the morning, to be consumed over 2 to 3 hours, and then wait. And this patient is going to pass stools after 1 to 1.5 hours of starting the PEGLEC. And the categorical instruction has to be till these stools are clear. So the nursing person has to make sure that the stools which are coming out are absolutely water clear. And if suppose you're not able to achieve that in one patient, more of PEGLEC can be given. Okay. So
Yes,
it has the end point has to be clear stools, because liquid stools which are not or partially cleared bowel is more of a disaster. Okay, so please always remember that. And can you in such a patient still be careful about, say, because as sir mentioned, Dr. Desai, which is very valid, that this patient is constipated and you may not actually get a chance to clear his bowels with PEGLEC preparation. So is there any other method which will help you?
Sir, for the clearing of the bowels,
Yes.
rectal enemas can be given, sir.
Yes, so rectal enemas can be given, and some of these patients can also be helped with, just in case there is a major luminal compromise, which I'm not expecting in this patient, because the patient's abdomen was absolutely soft and there were no other symptoms which you mentioned, which pointed towards complete or a near complete obstruction. Some of these patients, not this particular patient, later on, you might come across some patient who has a significant luminal compromise. They might need a stent or a tube decompression, but it is probably, let's not discuss that at this point of time. Okay. So you do a bowel preparation. Now you do a, what are you doing? Colonoscopy?
Yes, sir. Full length colonoscopy.
So in
Yes,
the
boss.
colonoscopy,
Yes.
what all are you trying to look at?
Sir, first of all, I'll start with the growth, the upper extent. I could not whether what is the upper extent, how much luminal compromise it is causing, whether the scope is negotiable through that luminal compromise or not, and the bulkiness. Then beyond that, any other synchronous lesion is there, and whether they are able to intubate and go to the terminal ileum, whether any other lesion or any evidence of any polyps is there, or any evidence of any other inflammatory pathology or disease is there, and whether a full-length colonoscopy is possible or not. Yes, and if any other lesion is there, then biopsy from that lesion.
Okay, so now the colonoscopy shows that on the right anterolateral wall of the rectum, there is an ulceroproliferative growth from which multiple biopsies were taken. The scope could be, the endoscopist went up to the terminal ileum. Remaining mucosa was normal, and there were no polyps or growths identified in the remaining colon. What next?
So now I would like staging in the cross-sectional investigation in the form of MRI pelvis.
By the way, do you have the colonoscopy
Biopsy.
for this patient?
No, sir. Actually, we have the biopsy findings, which is a poorly differentiated adenocarcinoma, but we don't have the full.
Okay, so you have the, okay, so let's go with what you already have. Let's ignore the well differentiated that I gave you. You mentioned it is a poorly differentiated carcinoma. What next?
Sir, next, and if the colonoscopy was done full length, so then now I would like to go a staging investigation of a MRI pelvis with.
So what did the colonoscopy say?
Yes, sir.
What did the colonoscopy show? At your end, have you
Sir,
done the
actually,
colonoscopy?
sir, no, we have not. We have not done it. We have just have one line single report written on the piece of paper, which says that that they could go till the ileum, no other lesion was visualized, and biopsies were taken from the growth. That is all.
Right. So, and the biopsies have shown
poorly differentiated.
Right. What next?
Sir, staging investigation in the form of a MRI pelvis with CT, abdomen, and thorax.
Okay.
Provided I have the biopsy report is there and the CEA levels I have already said.
Okay. What are the CEA levels?
Sir, they have not come. We have sent the CEA levels inside. They have not yet come. Report has not come.
Okay. So, and what does the cross-sectional imaging tell you?
Sir, cross-sectional imaging, sir. The MRI is available as I mentioned in the history. He was evaluated with an MRI outside.
Okay.
So the MRI report is MRI is already available with the patient, sir. Should I proceed?
Yes, please.
T2 we did imaging of the MRI pelvis.
So, do you have it on the slide?
Yes, sir. Are you able to visualize it, sir?
We are getting to see your PPT in the navigation mode, not on the slideshow mode.
Okay.
Oh, no.
One second, sir. I'll try to share it. Sir, is it visible now, sir?
Yes, we are getting to see the MRI pictures now.
This is a T2 weighted image of the MRI pelvis. The patient done elsewhere. Sir. It is showing probably a proliferative lesion in the left wall of the rectum, extending from 1 o'clock till 5 o'clock position, and it appears to be slightly infiltrating into the mesorectal fascia at one point, and it is causing partial luminal compromise, but it is not circumferential. And it is in more in the lower on the mid rectum.
Can you go back and point out the mesorectal fascia where you said that it might be infiltrating? Which is the mesorectal fascia?
It's a mesorectal fat, sir. This mesorectal fat, it appears to be at one point into the mesorectal fat, not the fascia, sir. The fat.
So be very specific. Mesorectal fascia would have made an altogether different meaning.
Yes, sir. Mesorectal fat.
Okay, so don't comment on the mesorectal fat also. This you should say that there is a transmural invasion.
Yes, sir.
Okay, so what invasion? What kind of invasion does it look like?
Sir, with regards to stage
Yes.
T3, sir.
Okay, great. Are you getting to see any nodes?
Sir, no, obviously large nodes are there. This probably the vessel because this is following up and down. And
what are the other important findings that you try to look at in an MRI?
sir, the how much of invasion into the mesorectal fat
Just
is
try.
there?
See,
And
I'm sorry, I'm interrupting you. Not about this particular patient, but when you look at the MRI pelvis of a patient with rectal cancer, what all do you try to look at? Just enumerate 1, 2, 3, 4, 5, 6, 7.
Sir, the growth, the level of the growth, how far it is above from
How
the
do you make
annulus
out the
to
level of the
member.
growth? What is the level of the growth?
Sir,
How? Let's go one by one. Where is the level of the growth?
yes, sir. Sir, we have to we will see the coronal and the sagittal sections and then comment whether it is in the
You have
first
all
of
the
all, it is
sections.
in the
You have all the
rectum.
sections in this patient. Show us.
Yes, sir, yes, sir.
Let's decide the level of the lesion first.
Yes, sir, showing, sir. Up. It appears to be more it is proliferative, also polypoidal type of a growth, which is in the more or less in the lower, confined to the lower rectum. And
what makes you feel it is polypoidal?
sir, the contour,
Okay.
probably the contour of the growth. And since from the anal was a distance about 7 to 8 centimeters, it is more or less confined in the lower rectum.
I have a communist background, so that rebel blood is flowing everywhere.
See,
And
let me try and correct you there. When we say polypoidal, a growth has a thin stalk and a thick major part which protrudes into the lumen. Okay, there is a difference between a polypoidal growth and a broad-based ulceroproliferative growth. What you are getting to see here is a broad-based ulceroproliferative growth, wherein the tip part is slightly polypoidal, which is hanging into the lumen. So I don't think it qualifies for a polypoidal growth as such. Okay, when you say polypoidal, it should have a narrow stalk, which it doesn't have. In fact, if you go to the coronal sections there, go back. Yeah, further down. Yeah. So see, just hang on there. Now in this particular picture also, you are getting to see the growth, but you are also getting to see the fluid intensity between the rectal wall and the growth, but you follow it down later, go to the next section, cut. Now you realize that it is
Lost.
basically broad-based ulceroproliferative growth, and that was just the hanging part of that ulceroproliferative growth. So it is not a polypoidal lesion. Okay.
Yes,
And it is usually very uncommon to have a polypoidal growth with a poorly differentiated histopathology. Okay.
Yes.
Try to keep the entire picture in your mind. Okay, let's go to the next. The next thing that you mentioned about one was the level of the growth. So what's the level? How do you classify the
Sir,
level?
sir, distance from the anal bud, sir. So generally 4 to 7 centimeters the lower rectum, 7 to 11 mid, and the 11 to 15 above, and some other considered as till 5 centimeters from the anal buds lower, 5 to 10 middle, and 10 to 15 upper rectum.
Yeah, that's a very arbitrary definition and it's very controversial, but
MRI.
what do you actually mean by lower third, middle third, and upper third rectal cancer? Let's not, because you know the length is always variable. You get
Yes,
my
sir.
point? The length of the rectum
Yes,
is
sir.
always variable. There can be a 5 feet person, there can be a 7 feet person. Okay, so it all varies. But now there has been clear definition for what is upper third, middle third, and lower third. Are you aware of that definition?
Sir, rectum is from the start of the pubic symphysis to the sacral promontory. That is the upper part, and generally this is we basically want to know
So
whether
that's
it is
where
above the rectum.
no, that's what is that's where the upper rectum starts. Okay.
Yes, sir.
Where does the upper rectum end?
Sir, below the first valve of above the first valve of Houston.
Valve is also a very variable kind of presentation. It may be seen in a distended rectum. It may not be seen in a distended rectum. So it's a very variable feature, and it is I know that's not the anatomical landmark that's used for classifying the upper rectum. So the upper rectum, actually, the sigmoidorectal junction ends, or the upper rectum starts at a line which joins the upper margin of the pubic symphysis with the sacral promontory.
Yes.
But it ends where the anterior peritoneal reflection ends. Okay? You got my point?
Sir, anterior peritoneal reflection. Okay, sir. It will be like a part. Is it a part of the middle in the insertion into the middle rectum?
Yeah, so that used to be the confusion, but it has now been adequately defined that and it is the anterior reflection, it is not the posterior, because anterior
Yes,
and the
sir.
posterior reflections, they
Different levels.
are at different levels. Okay. And there is still a confusion regarding how to identify on MR, because middle rectal is at the anterior peritoneal reflection level.
Yes, sir.
Okay.
Yes, sir.
And middle rectal is at the anterior peritoneal reflection level. Above the anterior peritoneal reflection level is the upper, and below that is the lower. So lower rectal third cancer, it is the entire, there's no serosal covering. So it's all a retroperitoneal kind of structure. Okay, so this is lower third as it is, because you could feel it digitally also, and
Yes, sir.
you have seen it on MRI also. Okay, so what's the usual prognosis? Prognostically, out of upper, middle, and lower third rectal cancers, which have the worst prognosis?
So generally, the upper one has very good prognosis. It can be treated similar to a colorectal colonic malignancy, but the middle and the lower third may, in the advanced stage, not in the early stage, may require a new adjuvant therapy, and they will need some local, because the risk of local regional recurrence is high in these cases, varying from 55 to 50%. So they need some form of additional therapy, and These tend to have slightly worse prognosis and increased risk of local recurrence and distant recurrence, as well as may require more extensive surgeries as compared to upper throat rectum.
Yes, you are right. So you have to say that although it might depend on many other variables, it has been shown by the literature that the lower third rectal cancers as a group have a poorer prognosis because of the technical implications in the treatment. Okay.
Yes.
Yes. Now, what else do you try to look for in the MRI? So level we have seen. Mesorectal fascia you have already shown. Where
Yes,
do you
sir.
look for the nodes?
Sir, nodes in the mesorectal fat, sir.
Can
And
you
depending on the level of
any
growth,
nodes? Can you
sir,
see and
I
can you show?
could not see any. 1 second, sir. I'll go back again, sir.
Yeah.
This one slight small node I can see, but at the level where the growth was there, this is the vessel, sir. Actually, this is the vessel.
Yeah.
No obvious enlarged malignant-looking lymph nodes, barring maybe.
Okay.
No,
What else
I
do
could
you
not
need?
see any of this. So the adjacent planes, depending on where the growth is, anterior wall, posterior wall, lateral wall, whether the adjacent planes indicate how.
Let's go one by one. Let's go one by one. You have
Yes,
shown
sir.
us the level. Okay. You have shown us the status of transmural invasion. You have shown there are no nodes. What's the next important feature that you're trying to look at?
How far the mesorectal fascia it is invading and how far the margin is, the circumferential.
So where is the mesorectal
CRM.
fascia? Tell me.
So this one. This
No,
one.
try to trace it. Try to trace it. I want you to trace it completely. Yes, in this picture. Try to trace it.
So can you see my arrow?
Yes, I can see, and you have traced it well. Good. So there is no mesorectal fascia involvement. Good. What else do you want to see?
In this, there is no involvement, but mesorectal fascia, if it is involved, until what extent, how far the margin of the
That is
mucus
okay.
of the
So it is not involved. What
yes.
more?
Sir,
What more do you want to see?
Nodes we have discussed. Then adjacent organs like the prostate, minor vesicles.
Okay. They're not
sacrum,
involved.
or they're not involved, sir.
One more important thing.
Sir, the sphincter involvement, sir, if it is in the lower rectum.
Okay. Yes. What else?
Sir,
Extramural vascular invasion.
vascular invasion, EMDI.
Yes. It is important to make out, and MRI tells you a good deal about it. MRI is supposed to be quite sensitive about it. Okay.
Yes, sir.
And what if it was an early lesion, say T1, T2, T3?
Sir, then, sir, in the MRI only, I have to tell.
Yeah. No. I'm just saying, if it was, say, the MRI showed you a T2 lesion, like this appears to be a T3 lesion. MRI showed you it is a T1 or a T2. Would you like to have some more investigation?
Yes, sir. Maybe a endorectal ultrasound can be done.
Yes.
It is a non-obstructing lesion to differentiate T1 from T2, because MRI is not very adept at that.
Great. Yeah. So there you would have wanted help of the endoscopic ultrasound to differentiate between T1 and T2, because that kind of changes the management of the treatment. Okay, so let's go beyond now MRI. Where are these sphincters? Show me. Sphincter.
Yes.
Okay.
Sir, here.
Okay.
External, internal, this hypodensity separated by this white line of intersphincteric fat.
Yeah. So when you say locally advanced, it is actually the intersphincteric plane which is invaded, because a lower third rectal cancer can actually come and encroach onto the internal sphincter, because it is the continuation of the rectal wall, the muscularis layer itself.
Yes,
now,
sir.
if it goes...
Sir, can I ask something?
Yes, sure, please.
Sir, one thing I wanted to ask, sir, like if we mention like locally advanced intersphincteric plane, like you mentioned, if you mentioned that T3 and T4, will it be like, right, sir, like T3, they have classified the MRI on the basis of how far it is going to sphincters?
Yes, of course, because T3 tells you only the thickness of invasion, but if it is T3 here at this level, which is near the anorectal angle, and if it on MRI shows that the intersphincteric plane is affected or invaded, you can call it locally advanced. Okay. Okay, let's go beyond MRI now. So the MRI is done. You now have the information. You have a poorly differentiated carcinoma, which is perhaps T3N0 based on the MRI findings that you have, and the patient was bleeding. What next?
Sir, CA levels have come.
What is CA? How much is the CA?
Yes, sir. Normal. Generally
Normal.
in non-smokers and smokers, in non-smokers, values up till 3 or 4 nanogram per ml can be taken. In smokers, they're slightly higher. Some labs mention 5 till 10 they can be taken.
So what is the CA level? Have you got the?
Sir, actually, they have sent. We have not received the reports.
What are you expecting?
Sir, actually, text mentions that 70 to 80% have are secretors, but in patients we have seen less percentage having CEA raised as compared to.
Yeah, what's the normal value of CEA?
Sir, for non-smokers till 4 to 5, and for smokers up till 7.5, I would say maybe till 10.
Yeah. Suppose this patient gets a CA of, say, I would say 3 or 4.
Yes, sir.
Is there any other factor which makes you think that the CA may be fallaciously low? Is there any other factor in this patient which might make you think that the CA...
anemia, sir, hemodilution, anemia-induced hemodilution?
No, I don't think it makes a difference.
Uh,
Poorly differentiated lesions tend to have not very high level of tumor markers. Okay, so always remember that in mind. Okay, although it is not a rule, but poorly differentiated lesions tend to have a lower CA than the moderately or the well differentiated lesions. Let's go further.
yes, sir.
What next? Now, what do you want to do next?
Sir, I would like to counsel the patient regarding his condition and since the other investigations like viral markers and which were remaining in the previous set of investigations, the random blood sugar and all, I would like to get them done and counsel the patient regarding his disease process, and that is the T3 disease, the options which he's having.
What counseling have you done?
Sir, told him regarding the disease, it is a malignant disease, and it is on the. I would also like to the CT thorax and the abdomen. I would like to get, and then if it is not metastatic, CA levels are within normal limits, then I would tell him this is a malignant disease of the rectum, and that he's losing blood from the same, and we have biopsy proof of the same, and I would like to tell him of the management options, like the I would in this case I would like to go for a neoadjuvant chemoradiotherapy followed by surgery, and in the surgery, since it is at a borderline of 4 centimeters, 4 to 5, then I would like to tell him regarding since he is not sexually active, he's at the present time he is not having any sphincter dysfunction or any other complaints.
We have not decided upon surgery. I mean, we have not reached the stage of surgery as yet. Let's go step by step. Okay. So you have the MRI, you have done the CT of the chest and the abdomen, which does not tell you any metastatic disease. And
yes, sir.
You have explained the patient about his disease. And
yes,
now you said that you want to send the patient for neoadjuvant treatment.
Yes, sir.
What kind of neoadjuvant treatment?
Sir, probably in this instance, it looks like a T3 and not disease, and it looks like an early T3 disease. And since it is in the lower rectum, I would like to transfer a short course radiotherapy.
Short course?
Yes, sir.
Why short course?
Sir, because
Why not long course?
one that in the good as classified by the European guidelines, the good tumor biology, the good, the intermediate, bad, ugly. So in the good and in the intermediate, sorry, we can, if we opt for new adjuvant therapy, then we can go for a short course. Radiotherapy has equal benefit for local regional control as compared to a long course therapy, and plus the fact that he's bleeding from the tumor, he will have an early surgery also, so that may help in short course radiotherapy followed by early surgery.
Short course radiotherapy followed by early surgery. What is your philosophy? What's the difference between short course radiotherapy and long course chemoradiation?
Sir, one difference is short course is only for local regional control. It sterilizes the local field only, and there is no effect on the systemic effect. And basically, it has the radiation effect on the tumor cells, but the tumor cells to die, they will take longer time, but that time is not given in the short course radiotherapy. Plus, the immediate complications of the therapy are less as compared to long course radiotherapy, or not. It is non-inferior to that. In the long course radiotherapy, it is for more advanced disease in which we want to achieve downstaging of the tumor.
So,
And for systemic control of the disease.
yeah, hang on. Let's go step by step. You said that short course is meant only for local sterilization to decrease the local recurrence of the disease, and you said that the long course chemoradiation is meant to downstage the disease. Here
short
is
course followed by early surgery, I mentioned.
short course, of course, both. Either way, we'll discuss about the surgery following short or long course. But you also mentioned that the long course chemoradiation
Yes, sir.
aims at downstaging the disease. Okay.
Or systemic control. Yes, sir.
And systemic control. Now, I have a very strong difference of opinion with you. Here is a patient who has a poorly differentiated adenocarcinoma in the lower third of rectum, which is already T3 and which is going near the intersphincteric plane. And by all criteria, it classifies as a locally advanced rectal cancer in the lower third as a poorly differentiated. So I think it has all the, I would say, adverse prognostic factors there. And these are the patients who require long course chemoradiation. These are exactly the type of patients who benefit from long course chemoradiation. Okay, so maybe you can go back and read, and we can certainly discuss about it on a phone call anytime, whenever you find it convenient. But these are exactly the kind of patients who require a long course chemoradiation. Okay. Now,
may I speak, Rajesh?
Yes, sir, please.
Yeah. The importance you have to realize between short course and long course is it's got no relation to the type of disease. Short course was used in Sweden to compare it with long course, and it was found equivalent to long course radiotherapy. There was no difference of opinion. I agree with you that long course chemoradiotherapy is used for systemic control and also local control. Both short course radiotherapy and long-term radiotherapy reduce the staging of the disease and make it possible to preserve the sphincters. The third thing I wanted to mention is the duration which you will wait after radiotherapy. How much is the optimum time you will wait? How many weeks?
The recent, if I am giving a short course radiotherapy followed by early surgery, we will recommend early surgery within 1 week, preferably within 3 days. If I am giving a long course radiotherapy followed by surgery, then it is 6 to 11 weeks. Some papers have mentioned an advantage of waiting till 8 weeks, so maybe 8 to 11 weeks, but others have refuted it. And the short course radiotherapy followed by delayed surgery, in that I have to wait for 4 to 8 weeks.
Yeah, okay. So you
Okay.
basically, as per the duration or duration till surgery is concerned, you have mentioned three categories. One is the short course radiation with immediate surgery within a week, short course radiation with delayed surgery at 4 to 8 weeks, and long course chemoradiation followed by surgery at usually about 8 to 10 weeks. Okay. So what are the advantages? How does the duration till surgery make a difference to the outcome, surgical outcome?
Sir, actually, we are giving time for the chemo radiation to show its effect on the tumor cells or downside the tumor, and that is the optimum time period of the cell cycle in which the cells will have rapidly divided cells would have died, and
So what
waiting
happens?
for more than that. Sorry.
Yeah. So what happens as and as you wait? So more the duration, how does it help?
So more the duration will allow more, like one cell cycle we have killed, then the other cell cycle will come in the rapidly dividing phase in 21 days. Then the radiation will have more effective stage like that. Chemotherapy will act as a radiation sensitizer, and the downstaging is appropriate at that interval as mentioned. So if we wait more, then it more likely to spread, more chance of meds. And if we wait less, then inadequate response or inadequate downstaging has been seen. So the appropriate timing has been decided on the basis of that.
Rajesh,
Yes, sir. So
there's a message from the organizers that we have overshot time and they would like us to wind up.
okay, okay, sir. Okay, sir. So I think I did. Can we have final comments from you, sir, please?
Yes, I don't know the presenter's name. I'm sorry, I missed your name.
Raghav.
Raghav?
Yes, sir. Yes.
Raghav, I was very pleased by two things that you said in your presentation. The first one is you actually listen to questions and you answer the questions appropriately. That's very good. So keep it up. And second one is before you went on to management, you did a proper metastatic workup, including a chest X-ray and chest CT. That is also very good. So please continue that. Some critical comments about your presentation. You started off very telegraphically. You should perhaps start off with a sentence like, my patient is a 66-year-old male, he's a shopkeeper in Jodhpur, and he presented with something like that. And then when you finish your history, don't wait for any questions. Just keep going. You finish history, summarize history. Then start off with examination and then summarize examination. It is for the examiner to stop you and then question you. So don't stop and say, can I go ahead with this? Your job is to present, okay? Next comment I have to make is you said along the way, malignant cause. And then you said malignant etiology of colon. I think you should avoid such comments. Make a diagnosis. Say cancer of the rectum or cancer of the colon. Okay. In family history, you made a broad statement saying there is no GI malignancy in the relatives. I think in colorectal cancer, you must be more specific. You must talk about how many siblings the patient has. What about the father? What about the mother? What about father's siblings? What about mother's siblings? And then the previous generation, patient's grandfather and his siblings, patient's grandmother and her siblings. You should take a more detailed history. And in your practice, with each patient, with every visit, your family history may change because relatives will come to visit the patient. And then they will recall so-and-so had a malignancy. So the family history profile will change with every visit of the patient. I want you to keep that in mind. I talked about summary. The summary should be one sentence for history and one sentence for examination. And as a rule, you must mention only positive findings unless the negative finding is so important that it helps you make a diagnosis. Okay, so that is something that is important. Every word in your summary must carry some weight. So work on the summary during the waiting time period when you have to present your patient. Okay. But overall, good performance. Congratulations. Rajesh,
Thank you.
please conclude and let's
Thank
finish.
you. Thank you for your comments, sir. And I think we should conclude. We have already overshot time. It was a good presentation, Raghav, and I'm happy that you guys are now, going to the next level of understanding of all these diseases. Particularly, I was happy with the way you read the MRI, and of course, your history was elaborate. What perhaps we need to do maybe at some of the subsequent sessions that go on to the operation and its details and how operative steps and technical challenges are taken care of. And that will perhaps help us to complete the subject in general without going into too much of details. But I think with the emerging concepts in all the malignancies and particularly for rectal cancer, we need to have a better concept and understanding about how multimodality treatment makes a difference to all of these patients. I think we should conclude here.
Thank you,
sir. Thank you. Thank you, sir. Thank you, Sitaram, sir. Thank you, Dr. Desai. Thank you, Raghav.
Thank you, sir.
Thanks
Thank you.
everyone for joining us. Thanks, Anand and Avinash. Thank you.